So now we're going to look at the role of the MRI during active surveillance and the PRECISE score. So active surveillance is an alternative to active treatment, meaning that we want to reduce over-treatment, but at the same time we want to ensure that we are giving the patient a curative treatment without losing the window of curability. The active surveillance protocol that the urologists usually do is a regular clinical examination, the PSA, and the prostate biopsy to confirm the presence of cancer, of course. So progression is defined using clinical or pathological thresholds. The problem here is that we have a lot of active surveillance protocols around the world with different selection criteria and different timing for imaging. Active surveillance is for patients with low or intermediate risk disease, and you can see here the definitions of these two type of cancer. But as I said before, there is a lot of variation in terms of when and how the biopsies are performed, but also when and how imaging is done. Here you can see the different eligibility criteria for active surveillance according to the different guidelines, the Americans, the European, the UK, and more. And you can see basically that there are no agreed guidelines around the world. But what we know actually is that no matter which guideline you are using, the outcome at 10 years is very good. So basically you can see that the 10-year overall survival is nearly 100% on patients on active surveillance. But we also know that more than 1/3 of patients leave active surveillance, both for disease upgrading, but also because they want to leave active surveillance because of anxiety. There is a role for MRI during active surveillance, but however, we do not have any robust data on the use of repeat MRI instead of repeat biopsies. So the follow-up at the moment is still with clinical and biopsy assessment, but also with MRI, even though MRI cannot be used as a standalone tool to trigger follow-up biopsies. This is really important. We can't rely only on MRI. These are the results from our cohort at UCLH in London. Basically, you can see that we have patients with 3+3 and 3+4 disease, and we stratified the Kaplan-Meier curves according to the presence or not of a visible lesion at baseline. As you can see here, we have a 3+3 NV, non-visible, 3+3 visible, 3+4 non-visible, and 3+4 visible. We define the event as a prostate cancer treatment, transition to watchful waiting, lesion 4+3 or higher, or any death. And you can see that if you have a visible lesion, either 3+3 or 3+4, so red and gray, you tend to progress much quicker than if you have a non-visible disease, 3+3 or 3+4. This is really important because when we start enrolling our patient in active surveillance, it is important if we have or don't have a visible lesion. Some studies have also shown the importance of diffusion weight imaging and the ADC value on active surveillance, showing that those who progress on active surveillance have a lower ADC values as expected. And also there are some nomograms that include here, as you can see, some MR features like the PRECISE score, the number of lesions, and the lesion volume on MRI. And finally, some also studies using radiomics based on T2 or ADC sequences. But now the core of this presentation is the PRECISE recommendations. Basically, these are recommendations that were set out in 2016 for the first time, and they try to answer a question: what is a radiological significant lesion during active surveillance? PRECISE is a 1 to 5 scale that you can apply only from the second MRI onwards, because you have to compare your current MRI with the previous one. If you have a PRECISE score of 3, this means that your MRI is stable, there are no changes. If you have a PRECISE score of 1 or 2, it means that there has been a regression or some changes, for example, with prostatitis that now are no longer visible. PRECISE score of 5, there is a difference, meaning that there has been radiological progression. With PRECISE 5, there is also stage progression, for example, T3A disease. And here again, these are some examples of the PRECISE scores. A previously enhancing area that no longer enhances is a PRECISE 1, or appearance of extraprostatic extension is a PRECISE 5. There is also a case report form where we can score up to 3 lesions and also give other features of the MRI that allow you to give a precise score. Here you can see a lesion in the left peripheral zone. You can see the lesion also on the ADC map and on the high value sequence, and you can see basically how you can calculate the tumor volume. Basically, you can do it by planimetry, slice by slice, or you can use the single diameter, 2 diameters, or the ellipsoid formula, which is ABCD by EF by 0.52. This is our pathway at UCLH, where we have a baseline MRI and then an MRI after 12 months, and our patients are on active surveillance. Then if you have a visible lesion at baseline, you will have another MRI at 3 years. If you do not have a lesion at baseline, you will have an MRI based on PSA kinetics. We tested the inter-observer variability with Professor Panebianco in Rome of the PRECISE score, and we saw that there is a high agreement, both as a kappa value and the percent agreement of the PRECISE scores between 2 expert radiologists, which is good. We also looked at the role of diffusion weight imaging in the PRECISE scores, and we calculated the ADC values in progressors and non-progressors of the lesion and of a healthy tissue. And as you can see here from the box plots, there is a trend. Basically, the ADC is lower if you have a higher PRECISE score. So radiological progression, lower ADC. We also analyze the different ways of measuring the tumor, as I said before, single diameter, biaxial, ellipsoid formula, planimetry, and we saw that there is a correlation between the PRECISE score 2 and 3, so no progression, and PRECISE score 5, progression. So no matter which kind of definition you use, planimetry, ellipsoid, biaxial, or maximum diameter, you will still have a difference in terms of radiological progression. And this is also represented here in this waterfall plot, when the black are the 4 and 5, and the yellow is the 2 and 3. So there is no, there is less change in terms of volume for the 2 and 3. MRI has been shown to be promising in the active surveillance setting, especially the PRECISE scores. And here you can see all the studies that used a scoring system for active surveillance, but there is still a lot of work to do. Here you can see a lesion in the left peripheral zone from A to D at baseline. This patient has only 3+3 in the right PZ and left anterior TZ. He had a 5 mm template biopsy that showed inflammation. After 1 year, from F to H, you can see that the area is has resolved, and there is only some minor enhancement in the left PZ, and this is a vessel. So this is a PRECISE 1. In this case, you have the baseline MRI A to C, where there are no lesions, and we know that we have only bilateral 1 mm Gleason 3+3. But after 1 year, it's a PRECISE 4 because there is a lesion in the left peripheral zone, as you can see from D to F. And this was targeted, and it was 4+3. And finally, another lesion in the left peripheral zone at baseline from A to D on all sequences. This was a 3+4 on truss. And actually, as you can see, it's a PRECISE 5 after 2 years because the lesion has increased in size and conspicuity, and there is also prostatic extension both on T2 and DCA sequences, and this was targeted 4+3 and actually 4+4 after surgery. As we have seen for PIQUAL, also for PRECISE, we can teach how to use PRECISE, and here you can see the difference of the area under a curve for different levels of expertise, and there has been an improvement before and after a course. But there is still work to be done. So PRECISE 4, for example, should be sufficient as a Biopsy threshold, but we do not have any quantitative features, for example, the ADC value, to assess radiological change. And these limitations have been shown in different reviews. One of the biggest limitation is that it is difficult to evaluate the conspicuity of the lesion, the visibility of the lesion, that is very subjective. And this is why we have now the second version of PRECISE. Again, feel free to download it, open access, where we have an updated version of PRECISE. It's a collaborative effort with different colleagues around the world, and basically the difference here is that now PRECISE 3 is divided into visible and non-visible, so 3V and 3 non-V. And then we also have a new PRECISE, which is X, which means that if your quality is not good, so you have a low PIQUAL score, you can't assess the PRECISE score because the quality is not good. There is an updated version of the case report form where we have to give the PIQUAL score, as you can see there. So we have to assess image quality, and then we can score up to 4 lesions. And here are the key points from this paper. The first one is that you should look at the lesion size on T2 weighted imaging. We should document all new MR sequences or new lesions, on the MRI. It's PRECISE 4, and we also give a PRECISE score on all the reports. Here you have a baseline Gleason 3+3 in the left peripheral zone. Unfortunately, after 18 months, we have artifacts from rectal air on the ADC map, so this is a PRECISE X. We cannot give a PRECISE score because the quality is not good. After 2 years, we see that actually the lesion has increased in size and conspicuity on the left, and actually this was targeted, and it was a post+3. This means that now we have a PRECISE 5, and this is really important because we have to have good quality images, otherwise we will not be able to monitor the radiological change over time. In this other lesion in the right anterior TZ, we have an initial 3+3. After 1 year, this has increased in size and conspicuity, PRECISE 4. And then this was targeted, more tumor was found. After 3 years, the lesion is also there, but it's stable compared to the latest MRI. So it's a PRECISE 3 compared to the second MRI, but it's a PRECISE 4 compared to the baseline. So this again is really important that you compare your current MRI with also the baseline and not only with the latest, because there can be progression from baseline, but not from the latest. So in conclusion, we can use PRECISE in a timely manner to prompt a biopsy or treatment for PRECISE 4 or 5. We could avoid biopsies if we have radiological stability 1, 3, and a stable PSA kinetics. This will allow us to reduce the burden of surveillance and also at healthcare systems. But of course, we need more data, more international data, and it's also really important to have good quality images and experienced reporters. And we have to work all together, also with our urologists in the MDT setting to achieve this. Thank you.
Thank you, Dr. Patilli. I think if we may postpone a question for after the next lecture speaker. Okay. لا postpone.